Hi, everyone on YouTube. This is Dr. Karla Lester with IMEcommunity.com and drkarlamd.com. That's Karla with a K. My metabolic telehealth for children and adolescents clinic is going. It's licensed in 10 states. So check out my websites and see if you are eligible to connect with me and be one of my patients. So today I'm going to talk on YouTube. I'm not giving medical advice. I'm not recommending medications, but I'm talking about the new anti-obesity medications that have been FDA approved for children and adolescents. And so listen up, because there's a lot of helpful information. Again, I'm not recommending these, and I have absolutely no conflicts and no disclosures, and I will never have any ties to the pharmaceutical industry, unlike a lot of doctors. So first of all, let me share my screen, and we're going to get going with the presentation. Okay, so let's go back here. So first of all, they're, instead of weight loss medications, they're classified as anti-obesity medications in children and teens. We don't like using the word, I don't like using that word, but that's the medical machine that is in place, unfortunately. And chronic disease of obesity is well known, and the comorbidities. And so that's how it's classified. So we're kind of stuck with it for now. So first of all, the results of the STEP Teens phase 3 trial of the once weekly subcutaneous, means just a shot either in the arm, maybe the thigh, or in your abdomen, subcutaneous semaglutide or Wegovy in adolescents age 12 to 18 years old with obesity are very promising. So this was published in November of 2022, and then there have been more recent studies that show promising results. This one was published in the New England Journal of Medicine. The study showed that patients who received semaglutide versus placebo, so nothing, had greater reductions in body weight, improvements in waist circumference, so that's a measurement around your waist, hemoglobin A1C, which is a measurement for diabetes, lipids, so that's your cholesterol levels, except for HDL, which is a good cholesterol, and alanine aminotransferase, which is a liver function, that's a liver enzyme. And so oftentimes people will have, even teens, even children, I've taken care of a lot of patients who have what's called non-alcoholic fatty liver disease. So showing decreases in those numbers of ALT is the abbreviation for that, is a good thing. Quality of life measures were better in the semaglutide group, so the group that got the medication. And also, as to be expected, adverse gastrointestinal events were greater with semaglutide compared with placebo. So we know that if you follow these people who take the medications, that there are side effects. There's reflux, there's constipation, sometimes nausea, sometimes vomiting, sometimes more rarely gallbladder issues, or even more rarely something called pancreatitis. So these are all things that have to be followed closely. It's not a simple decision. Indications for any sort of medication that is a weight loss or anti-obesity medication in a pediatric patient, which includes adolescents, is the severity of the obesity, the comorbidities. So do they have prediabetes? Do they have diabetes? Do they have PCOS? Do they have non-alcoholic fatty liver disease? Do they have metabolic syndrome, hypertension, those kinds of things? The BMI trajectory. So is this patient on when you follow the growth chart, have they been gaining weight rapidly and nothing is working? The response to lifestyle therapy, which I have a lot of conjecture about this. I have a lot of issues with when we say that lifestyle therapy has failed, but have they, worked hard and worked with a dietitian? Have they worked with a clinic, with a program to, work on fitness, to create healthy habits, and they're still having issues with weight gain? Obviously, the patient's preferences. A lot of teens are like, no, thank you. The family preferences. Families may also have that same frame of mind. Have they had metabolic bariatric surgery? Those are considerations. Are they considering it, or have they had it and they want to optimize maybe their reduction and prevention of the comorbidities after the surgery? Do they have a history of eating disorders? So this is something I do a lot of screening for with my patients, to make sure that we're not just focused on weight. Obviously, if there's restriction there, if there's binge eating, if there's bulimia, then we need to have you referred to a therapist to work on cognitive behavioral therapy first. If there's body dysmorphia, we're dealing with something more like a mental health issue that we need to address, and that's going to be the primary focus. Is there insulin resistance? I add that in here, and I talk about insulin resistance a lot. So, that's going to show up maybe on your body, that's going to show up in your labs when you're going to have prediabetes, have fatty liver disease, have increased waist circumference. Maybe you're going to have a darkening around your neck called acanthosis nigricans. Maybe it runs in your family. Maybe you have a genetic syndrome. These are more rare, but we don't test for these enough. And so a child who has had developmental delay or had severe obesity early on in life, or has something called hyperphagia where they just can't be satiated, they can't get full, that's a sign potentially of a genetic syndrome. And also if there is obesity in their family. If the patient has strong hunger and then poor satiety, so they may benefit from the effects of these GLP-1 like receptor agonists like Wegovy, potentially in their brain that has an effect to decrease the cravings in the brain. And then the age, obviously, and the developmental stage. This takes a lot to add in these. I look at these medications as a tool, and it takes a lot to really be able to be to the point where a patient and even their family is mature enough to really understand the use of these medications. Okay, so suggested indications for starting an anti-obesity medication, maybe even upon the first visit. And this is per the American Academy of Pediatrics Clinical Practice Guidelines. There's never a rush, but if it's a tool and the family's interested in it, the patient's interested in it, if the physician isn't comfortable prescribing, maybe they have a pediatric weight management program or a doctor who is board certified through the American Board of Obesity Medicine. So go to abom.org. I am board certified. There aren't a lot of us out there, especially in pediatrics. So if the patient is 12 years or older, and you might consider if they have class 1, 2, or 3 obesity. So that's, class 3 is the BMI is 30 or higher, and then 27 to up to 30 for 2. And then I think it's 25 to 27 for 1. And then if they are 6 to 11 years, class 2 and 3. Listen, there's a lot. I'm just putting this out there that this is what the guidelines say. I don't personally ascribe to being so aggressive, but I'm putting it out there because that's what the AAP has put out. And so it's just for consideration. It's informational purposes only. So medication selection, we have to think about the mechanism of the action, depending on what the patient is dealing with. If they have a lot of, food cravings, if they have nighttime eating, then they may benefit from something like Qsymia, which has phentermine and topiramate, or just topiramate alone if they have nighttime eating, versus starting them on a GLP-1 receptor agonist. We have to look at the side effect profile and all the things going on with the patient's comorbidities. So maybe they may benefit from one versus another. Obviously, cost and access to the medications are an issue, and the patient and the family preference, and the patient's eating phenotype. So, kind of what are their habits? So like I said, like if they have more nighttime eating, a lot more cravings, if they have like binge eating disorder, and Vyvanse is not an anti-obesity medication, but it does help for binge eating disorder and has that indication. Okay, so here's the medications that are FDA approved for pediatric obesity. So phentermine, which is a stimulant. It's in lower doses than what we used to prescribe years ago. Of course, I never did. As fen-phen. And so people who have anxiety, patients who have anxiety, you have hypertension or problems with your vision, like something like glaucoma or that runs in your family, then you would not be a candidate for phentermine. Orlistat is the one that you eat your food and you kind of poop it out. So it's like a decreases absorption of food. It has a lot of side effects. We don't really prescribe it. Liraglutide is a GLP-1 receptor agonist that's given to patients with type 2 diabetes, and it is a daily injection. Phentermine topiramate is Qsymia, like I talked about. So that's the combination of phentermine plus topiramate. You can also do the topiramate like separately. Like they prescribe the phentermine, you may not get the weight loss effects, but you may have decreased cravings, decreased nighttime eating. And then the semaglutide, which is also known as Wegovy. And then the other ones I mentioned, like I mentioned, Vyvanse, that's approved for, excuse me, ADHD in children 6 years old and binge eating disorder, 18 years old, and that's administered orally once daily, long acting. And there's the doses and the mechanism of action. We're getting real sciencey here. Okay, so let's talk a little bit about the GLP-1 mechanisms of action. So the main effect of medications like Wegovy, Ozempic, Mounjaro, liraglutide, which is also known as Saxenda, is it exerts its main effect by stimulating glucose-dependent insulin release from the pancreatic islet cells. Wow. Slows gastric emptying, which is the one we know about. So it slows the emptying of the food from the stomach, so you feel fuller longer. It inhibits post-meal glucagon release and reduces food intake. So they essentially work by reducing the appetite and feelings of hunger, slowing the release of food from the stomach, and increasing feelings of fullness after eating. And some, like Mounjaro, and then most of them, have the added action of quieting the mind through the GLP-1 receptors in the brain, but we have GLP-1 receptors kind of everywhere. Okay, so here's the medications that are approved by the FDA and their indication. Okay, so liraglutide and semaglutide are the main ones. And so for obesity, so as an anti-obesity medication, Saxenda 3 milligrams, which is an everyday injection, subcutaneous, or Victoza for the treatment of type 2 diabetes is in a lower dose, and that's for 10 years old or greater. And then semaglutide is the Wegovy or Ozempic at a lower dose. So it's approved for 12 years or older, as Wegovy at 2.4 milligrams, and then Ozempic is for 18 years or older. And that is approved for type 2 diabetes by the FDA. There's other medications specifically for type 2 diabetes, and those are Trulicity, Budarian, and Mounjaro. And the Mounjaro is the one we hear about a lot, especially on TikTok. And we, that's usually for people who are 18 and older. So contraindications are if you've had a history of, in your family, medullary thyroid carcinoma, something called MEN type 2, which is multi-endocrine neoplasia type 2. These are rare things, obviously pregnancy. And then cautions to taking it are pancreatitis, gallbladder disease, or if you're taking insulin. And obviously you have to work with your doctor on all this, okay? Again, not any medical information, it's just information. And so you work with your doctor, because if you're being treated with other medications, if you have type 2 diabetes per se, and you start one of these medications, your blood sugar may really go down quickly. So you have to be maybe weaned or tapered off those, and they have to really manage that and follow that closely and know what they're doing. Okay. So the biggest benefit of the GLP-1 agonist, I think, is the delayed gastric emptying. So you feel fuller longer. You have to make sure you're hydrated, you're doing enough protein. And especially with teens, I mean, that is a really huge deal. You have to make sure you're eating. And they also get the quiet mind. So, you're just really stuck in a craving mind, thinking about food all day. And for the first time, a lot of patients say their mind is not constantly food seeking and craving. And there's a lot of other work that has to happen along with, these are just one tool. So they feel fuller faster and they have less cravings. And what I think is helpful is, we talk all the time about weight loss, but the most important thing is that they're really getting to the core issue of the insulin resistance. And they're treating that and helping your body become more insulin sensitive or responsive. So it's kind of helping to restore the balance of your hormones like insulin. And it helps to decrease sugar cravings from ultra processed foods, because ultra processed foods are everywhere. And so that's very helpful. Weight gain is a byproduct of insulin resistance. Weight loss is a byproduct of reversing it. So the weight gain is almost like a symptom, and the weight loss is a byproduct of the treatment of the root cause of the problem. You've got to make sure, again, you get adequate intake and you don't get into a restrictive eating pattern that's going to rebound as binging if you have to stop your medication, because maybe you can't get access to the medication anymore. Maybe there's a national shortage of the medication. Maybe you have a side effect from it. Maybe you don't want to take it anymore. And so it doesn't automatically mean that you have to take it for life or that you're going to rebound and gain all the weight back. But the main thing is that you need to have all the tools in place to create healthy habits and the support that you need, because we can't go for one singular fix. Okay. The instant gratification of dopamine from ultra processed foods is so powerful. We know what dopamine is, that feel good zing we get in our brain. So for me, helping teen patients create a dopamine balance so that their daily life is full of true rewarding gratification is imperative. Even with the use of the GLP-1 agonist, we don't want to depend on just one thing. Okay, obviously, and I work with my patients, so go to drkarlamd.com and get in on my metabolic telehealth clinic if you're in the 10 states that I am licensed in. And you can schedule an appointment with me, a consultation with me from the website, which is really exciting and cool. And so there are issues with getting coverage and getting the medications approved. So you have to write something called a prior authorization along with submitting the prescription to the pharmacist. So there's a lot of work that goes into that. And one of the things that I want teens to stay away from is if we just talk about this as a possible tool that's out there, one thing we don't want to do is focus just on weight. We want to focus on all of health. And then also you have autonomy, so you get to choose, because that's what's really important. And we don't want teens to ever think that they're broken and there's anything wrong with their body and they need this one fix. And we don't want to perpetuate that as doctors either. So it's just one part of a whole approach to health. And, it's really a lot of very heavy ethical considerations for the family too. Okay, so that's that. I'm going to stop sharing. And please reach out to drkarlamd.com, get in on a specialty consultation with me, go to imecommunity.com, that's my website, and make sure you subscribe to my YouTube channel and share with everybody, because my approach is kind of unique. So we're bringing all this together, getting a holistic approach to health and just medication. Now you have a lot of information on, and know that they can be one tool and you don't have to decide now. You have a whole lifetime ahead of you. Okay. All right. I hope that's helpful. Thank you.